Good afternoon, everyone. I'd like to welcome you all to today's John Dossiter Health Ethics Seminar. Just as a reminder to everyone that we'll be keeping microphones muted during the course of the presentation. Following the presentation, there'll be time for discussion, at which point we'll unmute the microphones. Please feel free, however, to put any comments into the chat box or questions, and I'll certainly read those comments out loud for our speaker to support discussion. I also put a reminder in the chat box with regards to the Dossiter Health Ethics Seminar upcoming symposium, which will be on moral distress next week. At this point, I'd like to introduce Dr. Aris Waslenko. Eric is a palliative care physician, a clinical ethicist, and an adjunct member of the Dossiter Health Ethics Center. He does a great deal of work towards medical education of students in various health faculties. He's sat on multiple committees, provincially and nationally and internationally, supporting work in health ethics around work for goals of care designation, allocation of scarce resources, and so forth. We are extremely fortunate to have Eric as a speaker today. I recognize he's very sought after, being very articulate and talking around sometimes very challenging and difficult topics. So without further ado, I'll turn it over to you, Eric.
Thanks very much, Michael, and welcome to all the participants. Hope you're having a good afternoon. Talking today about restricted visiting in care settings during the COVID-19 pandemic. And my byline for this talk is, it's well-intentioned what we've done, but ask the question, should harm resulting from what we've done be minimized? It's a pretty obvious answer, I think, for most of us, and I'm going to challenge a little bit about that answer and why, although we believe it should be minimized, we haven't maybe done all the things that we can from the perspective of the way we think about this problem. I'm just trying to advance my slide here.
It should be in the, oh, there it is.
All right, so I'm going to start first with land acknowledgement, if I may. I acknowledge that Alberta rests on the territories of Treaties 6, 7, and 8, and the Métis regions 1, 2, 3, 5, and 6. This territory is home to many Indigenous peoples. Where I reside in my home is traditional Blackfoot territory, and it is in the vicinity of an important meeting place for them. I respect the treaties that were made on all these territories. I acknowledge the harms and mistakes of the past and commit myself to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. As part of my personal and professional commitment, this particular month, I'm learning more about calls to action numbers 19 and 20 of the Truth and Reconciliation Commission in the section on health and healthcare. I have no conflicts to declare. I've taken a strong advocacy position. However, I need to let people know around this issue and have advocated publicly and privately about it. And some of that will come through, I think, pretty loud and clear today. I do have faculty appointments at the U of C and the U of A. I'm Medical Director of Health System Ethics and Policy from the Health Quality Council of Alberta. And I'm also an ethics advisor, a committee member with a number of provincial and national government and health agencies, some of whom are addressing this issue as well. So I wanted to declare that. Here's my objective today. I want to stimulate thinking from a somewhat different direction about a conflicting public health imperative. And my prod for you, and I'm going to provoke you a bit, is regarding both the problem and the potential solutions. In a pandemic where people can die from the infectious illness, there are dual priority health objectives. We want to prevent the spread of the illness, and we want to save lives. And those are pretty obvious. We've heard about those in lots of venues. But I'm going to contend that we can't stop at those objectives. There's at least another that is now receiving appropriate attention, and some would say perhaps too late. So in a situation where the illness causes death itself directly, and death and suffering from other unintended consequences of our efforts to limit the spread, we have an equally important societal obligation to facilitate the best living and dying and care that is possible for vulnerable people under our care. So who am I thinking about today? I want to be clear, my talk will have a little bit of theory, but hopefully not too much, a little bit of societal philosophy, not formal, and a few practical ideas, but it's grounded in real people. And today, and while I have been preparing this talk, I've been thinking a lot about 6 real people, and I'll characterize them in this way, even though I'm generalizing this a bit. Thinking about some leaders. They're in an awful bind, and they're meeting very conflicting imperatives, doing the best they can, having to do this for all of us. I'm thinking about a hospice facility manager who faces immense pressure and moral anguish about not being able to meet the usual exceptional care standards and support for grieving families and her distressed staff. I'm thinking about a patient I know who needs a care facility but is frightened to go, in part because they know they won't be able to have visitors. I'm thinking about a resident I know who has moderate dementia and doesn't understand why his familiar family no longer visits every day. Thinking about a woman with a large family who depends on her, who's working at a care home in long-term care, but's fearful to go to work and bring home COVID to her family potentially, and also afraid that she might transmit the virus to a vulnerable patient if she's back and forth from work. And I'm also thinking about a father who couldn't sufficiently be with his dying son as his son transitioned to a hospice during the early quarantine period before he died. In the scope, I want to address my comments to the part of the system involved with caring for people where they live in congregate settings. So they live with others and they're cared for with others. They are in lots of ways uniquely vulnerable, and their situation necessitates that they live in a care facility with others, and those others are similar. And we'll use the term congregate living care settings throughout the course of today. I'm including care homes that are providing a multitude of levels of care intensity and complexity, as well as residential hospices for end-of-life care. This involves mostly elderly people, but certainly not always elderly people. And I will not be directly addressing acute care facilities and the visitation within those facilities. I also want to first acknowledge people's dedication and their efforts. Look, our health system leaders, facility operators, in my view, have done just a remarkable job having to meet the challenges of this novel, dangerous pathogen that nobody has experienced before. They've adapted intelligently. They've been committed in really strong ways to the principles under which they operate. And also the staff and leaders in our facilities who work with really outstanding dedication in both uncertain and difficult conditions where they face personal risk and they're vulnerable as well, together with their families. And I also want to acknowledge the families and advocates and researchers and policymakers, businesses, all who are working really hard and creatively in tough circumstances. And I say all that out front because some of what I might say could sound critical, and I want to always keep in mind these really difficult circumstances that people are working with and have done fabulous work around. And that leads me to the first notion from an ethics sort of principle point of view. It's called solidarity. So while we have a duty to speak up and to advocate and to do our part to improve situations and to be also on alert for impaired motivations, we also have a duty to work cooperatively within our structures societally so that we avoid chaos. We can't all be doing the things that we want to do or believe is right and just say the rest of the world doesn't matter. We want to avoid the resulting harm from chaos, in other words. So that means we need to listen to and work with authorities. We trust them that they have the expertise. We trust them that they have skills to manage competing imperatives. They work within principles, including the attention to best evidence. And importantly, we trust in their underlying motives and goodness. It means that we should avoid inflammatory public commentary, especially from positions of opinion without full knowledge. It means that we have to recognize there are places to insert our advocacy and knowledge, and we do that carefully, but without reservation. We recognize venues and approaches that will not be helpful in which to advocate. We avoid commiserating with others, and we're unafraid to be truthful and transparent in our views. But it also means we should check our egos at the door. There are some corollary procedural values that arise from solidarity and other things. So we want to be transparent regarding our actions, what we know, what we don't know, how and when and through whom we regularly communicate with the public and our stakeholders. We want to be inclusive. So how we go about collecting the views of people, including them in decision-making. We'll talk a little bit more about that later. How we want to assure that those most affected are not just informed people, but are also at the decisional tables in some manner. We use the concept of subsidiarity. So we say that we want to support decision-making levels where it's appropriate to do so that are closest to the interface of the impact. Here, in this example, where care and accommodation are provided. And I think our leaders have done that really well, especially secondarily, where they've said, look, each manager of a home or of a hospice needs to have the flexibility to make decisions, make exceptions, and to modify what's being done within a broad frame so that the people that they're caring for and caring about can be dealt with in the best way possible. And we always have to have an appeals mechanism and revisability. So where are Canadians dying from this illness? According to CIHI, as of May 25th, 2020, 81.1% of all deaths from COVID-19 in Canada were in long-term care. And the total COVID deaths per million population in Canada was 175.5. And I put that number into comparative to just a couple of other countries. There's a range or a list of 16 OECD countries that we compare to. The next highest for deaths within long-term care was Spain at 66%. And then Australia was 27.5%. Our average in Canada is about double the average for the other 16 OECD countries. Spain has 574 deaths per million. Australia had only 3.4 deaths per million. So those provide you a little bit of a range. Also want to remember, because this statistic has been quoted a lot of time as a source of what some people call a national embarrassment. In Canada, we also have the third highest percentage of long-term care residents over age 80. And we know from epidemiologic data that people that are over the age of 80 have a much higher chance of dying because of their frailty, because of weakened immune systems that occurs with age naturally, and because of the comorbidities as people get older. So what's the conundrum? We feel compelled to keep vulnerable people safe. We don't want them to contract this illness, mostly because very possibly they'll die from it, especially in our congregate care settings. We also wish to keep our healthcare workers and their families safe. While doing so, we want to avoid the unintended major consequences of what's been viewed as a required strategy to isolate people and keep them from getting the illness. In other words, we have this duty to protect, to minimize death and minimize infection spread to others. And we remember, while that this is a killing illness in the population that we're referencing today in long-term care and hospices and other places of congregate care. We also have a duty to not cause other and perhaps worse harms while we're protecting people from death. And so we ask the question rightly, and I know everyone is asking this question, have we done one of these things at the expense of the other? And if so, can that be justified in any way? So there are steps taken by the Chief Medical Officer of Health under her legislation that are meant to, in Alberta, so Dr. Hinshaw, and there are Chief Medical Officers of Health in all other jurisdictions in the country. Under that legislation, at least in Alberta, The CMOH is meant to suppress the illness in those who may be infected, protect those not already exposed, break that transmission chain, preventing spread, and remove the source of infection. Our leaders are also cognizant, and I know that they are deeply cognizant of the consequences of social and economic disruption from their orders, and that also are meant to protect from unintended negative consequences to the overall health and wellness of the people that are subject to their orders. All these motivations are informed by and animate societal values. We use communal resources to protect all from harm to the degree possible. And that predicates the basis of our healthcare system that we rely on. We also want to maximally protect people who are particularly vulnerable. And many of us believe that part of our duty as a society is to assure that we're overdoing the work we can with those who are particularly vulnerable, in part because they haven't had the benefit of receiving and having access to equitably to the communal resources that the rest of us have. So the Public Health Agency of Canada characterizes things this way in their work to try to develop a framework for COVID and for other ethics issues. And I'll declare up front that I've just finished a term as the chair of the Public Health Agency of Canada Ethics Consultative Group. So some of the work of our committee during that time was to develop these principles. So I need to declare that for transparency. Foundationally, we want to promote trust and a fair distribution of burdens and benefits. And we do this by respecting people, communities, and human rights, by promoting their well-being, minimizing harm, and working together. We also want to balance the well-being and minimization of harm by attending to these things: effectiveness, proportionality, and that's a really important one in this issue because we want to balance the benefits and the risks of harms. And the measures always need to be proportionate to the threats and the risks that there are. So if this is a killing illness, that bears greater impact and import in the way that we decide about the measures to protect the public versus if it wasn't such a serious illness. While we're doing these measures, we want to make sure that we're using means that are the least restrictive on those people, on those people who are subject to our measures. And of course, we want to support those people who are facing risks while they protect others and minimize the burdens of those who are facing those risks. There's also the precautionary principle, and we want to make sure that we take action even in the face of scientific uncertainty and not let the lack of experience and knowledge that we have, that we might be missing from science, stop us from actually taking actions that seem appropriate in the best way possible. And then there is the final, sorry, I'm struggling to get these slides advanced. The final procedural considerations of accountability, openness, and transparency, being inclusive, being responsive, and intersectionality. There's a reference to where you can see more and read more about each of those principles and values. So what might be the problem? I think it's an entirely plausible view, as people have written about, that we have simply inadequate funding in congregate care settings, and also have prepared inappropriately or not sufficiently in this sector in advance. And also that the sector writ large is disadvantaged in its focus from public and public health authorities and the rest of society. I'd recommend to you all reading the really important Royal Society of Canada paper on restoring trust, COVID-19 and the future of long-term care, co-authored by a number of people, including some that you all know from Alberta. It's really compelling reading and it's important. Interestingly, we've seen recent articles in the newspaper and other sources about the very generous COVID-19 income supports that have vastly outpaced those income supports in other developed nations, at least through the OECD. And it's been reported that household incomes in Canada have increased in the second quarter of 2020 by 11%, which is unprecedented in a time of economic contraction. The economy in Canada actually contracted by 10% during the same time period. Household savings, we've learned now, have also increased. That's a good thing in many ways, and it's certainly good if it's distributed income and wealth more broadly, especially to those who need it. Meanwhile, while we've been spending this money in what felt to be by many an appropriate way, in our sector, Rome is burning. And so we hear media headlines like this: nursing homes under siege again, strict COVID-19 protocols are leaving seniors lonely, depressed, and wondering, is it worth it to live? Should more be done to protect seniors' facilities as the cases rise in Alberta? And those are all accessible. We hear in those stories some very dramatic and compelling stories of the harm that people have felt and that their families have felt from the restricted visiting and other restrictions within long-term care and other congregate care settings. There are policy interventions, and the CIHI's published a really neat paper where they demonstrate in different countries, by the time that each country, and this normalizes it or standardizes it, by the time the country has reached its 1,000th case, what kind of policy interventions are promulgated nationally. Here's a list of some of them that they talked about: long-term care infection control and audit, rapid response prevention and control in long-term care, isolation wards for infected residents, testing of all residents and staff, hazard pay for staff, recruitment and surge staffing, one-to-one staffing for long-term care residents with dementia, funding for PPE, all the kinds of things that we would think would be really sensible. None of those had actually been promulgated as policy directions nationally, consistently, by the time of our 1,000th case, where in other countries, some of them had. We did enforce, by the time of the 1,000th case, restriction of visitors to long-term care. So what might be the problem? And I'm trying to look through the lens of a deeper view. And I'm going to make the claim that it's a flawed mental model of elderly and vulnerable persons and of the family and community responsibilities that we all have towards them. And the flawed model includes a certain notion about the healthcare system and its authority and its accountabilities, the duties they have, that maybe absolves the community, us, of authority and responsibility, and perhaps promotes denial of place and distance, that we ought not to be or don't need to be present in people's living, remembering that in congregate care settings, and including in hospices, people are actually living in advance of the time that they're going to die. So there's some language that we've incorporated into our everyday thinking and discourse. We demand quality and safety. We make sure that trained professionals and managers are around, but they know better than the rest of us. We need efficiency. We need to know that the system will manage things for us. Somebody owns these facilities. Somebody runs these facilities. Visiting hours exist and they're logical and necessary. And it's all about care and protection for everybody else in the congregate care settings. So these things are expected and accepted, and they form part of the language that we've incorporated. I'm not sure that they're all right, though. So there's an interesting model that we might want to contemplate instead. I'm just going to move ahead and just see if I've skipped. Sorry. We might want to say that we should move from, as a society, as community members, look, there's a place that's set up, it's established, it's got all these standards and bits of quality, and they're there to care for this person that I care about. Maybe we should move to, can we as family be invited in to assist in this person's care? And maybe eventually, extending beyond that, we should be saying, I appreciate you caring for X while we cannot be there. And that might at least apply for residents who actually have family or community to support them. Here's the second underlying assumption or problem. Our attention is focused on death. We want to prevent it at almost all costs in our society. And we measure our performance via death statistics. And we assert that it is the pinnacle risk. And I'm going to claim that because of the way that we think about this problem and the way that we measure it and report about the problem and every day. When I believe that our attention should also be focused on addressing the living and the accompanying experience for those still vulnerable citizens who will not die from COVID, and also addressing the living and accompanying experience for those who contract COVID and will die, and also for those people who are preparing for death from a whole myriad of other causes. And that we should measure performance around measures of suffering and its attenuation, how well we're doing that, and the positive measures of healthy experiences. So we have this daily COVID data that many of us are looking at once a day, twice a day, or more often. How do we know how well all those people who died of COVID-19 in care facilities were adequately palliated? We likely don't. But all of society knows almost daily how many people who got to hospital were treated in an ICU, for instance. Would you be surprised to have a daily update of the numbers of people in hospices and long-term care or DSL who suffered today from loneliness, isolation, fear, confusion because of no comforting familiar face, of weakened immune systems due to stress, of failure to thrive, of aggressive behaviors due to dementia that no one's there to take care of? And maybe a daily update of the numbers of deeply distressed staff who could not provide the usual attentive care, and the morally distressed managers who have to deny access to family members, instead of just getting numbers of people who died or who were in hospital or who were in ICU. So here's my claim. We can't eliminate the risk of contracting COVID-19. We can only mitigate it and reduce the risk acceptably. It cannot be kept out. We cannot eliminate all other harms or the risks of magnifying those harms, but we can and should definitely reduce and minimize those other harms through a concerted effort to think differently, along with an expectation and high expectation and a demand that we have for success in that endeavor. When you think about risk of contracting the illness or of the measures that we're invoking in order to try to mitigate harm, we have to think of it as the matrix that we've talked about in previous talks, the likelihood of the event X occurring and the nature and the degree of the harm if the event X actually occurs. And that matrix determines how aggressively we need to do things to protect and how aggressively we need to do things to mitigate the harms of whatever policies we put into place. So let's accept that some death will occur, and let's attend very carefully to optimizing the dying experience. It distresses me that we haven't thought about and talked about each of those people who are a statistic of who have died. And I think it's wonderful the way in public discourse people pay attention, those who report to us very carefully, emotionally, and appropriately to honor the fact that those people have died and the trauma for them. But it's distressing when the rest of us are not thinking in our heads about what was that experience like for those individual people during the time that led up to their death and for the actual death experience and for those who are their loved ones. There's a special problem of COVID visitation during care at the end of life, and especially in hospices, but not only so. It's in all congregate care settings. It certainly is in hospital as well, but I'm not talking about that today. So the experience of dying, and I'm including here both the time leading up to death, preparing for anticipated death, and the actual death, is critically important for the person who's dying. We know that. That's pretty obvious. It's also critically important for those within the dying person's circle. they will live the rest of their lives with the vivid memories of this experience. It's insufficient for us, I'm going to claim, to just acknowledge the loneliness of isolation. If we don't enable people in our care to attend to their legacy, preparations for death, completion of their relationships, to experience human touch with trusted others, to have their anxieties eased, to give and receive love, we cause great harm to their very personhood. That harm also stays with their bereaved others and with their other care providers. People go to places like hospices specifically for the opportunity to receive the encompassing care provided there and to be able to live as fully as they can with their loved ones in this key time of their lives, preparing for their eventual death. So I want to challenge a whole number of these societal premises. So first one, death is to be avoided at all costs as the primary measure. Death is much worse than suffering, and it's much worse than poor living. The health system owns the problem and solutions. Long-term care is primarily a care facility. And I'm hoping that the way I'm phrasing these statements, it's obvious to you. I'm not supporting these. These are premises that I think we need to be challenging. Let's remember that long-term care is a place where people live their days who need some extra care. Here's another one, the premise that families and visitors are a vector of infection, so we better keep them out if we can. And they're a nice to have part of the care team, maybe. And I'm going to make the argument that they're an absolutely critical part of the care team and need to be looked at differently. All families, residents, and staff feel the same way. It's just not true. So the HQCA, which is an organization that I work with, conducted some really important studies, both through survey and interviews, for a time period from late March until late July of 2020, with survey responses from about 9,600 family members and 385 residents in continuing care sites in Alberta, and then some in-depth interviews with 43 residents, including both outbreak and non-outbreak sites. And some details can be found at their website, hqca.ca, along with some that have not yet been published but are being worked on currently now. And the fantastic team at the HQCA has provided some of these things publicly now, and it's continuing to analyze the results of what I think is a pretty substantial number of informants. So most family members thought that restrictions and lifting the restrictions actually struck a pretty good balance. A number of family members, and in fact quite many, thought the restrictions went too far and discussed the decline in the quality of their care being provided to their loved ones. This is from family members, because they were restricted from visiting. And so they noted that essential care tasks for family members who previously were supported by the family members were left to staff to undertake, and without additional staff and sometimes unfamiliar staff, and the extra safety measures and protocols, all this left staff overworked and unable always to attend to those needs of the residents. Quality of life in particular for these people suffered. And it was noted that the impact of visiting restrictions among residents with dementia were particularly severe. And the family members who were part of that care circle were negatively affected as well. For residents, many felt that the restrictions went too far, and some even described in very graphic language their situation as being similar to being in jail. Lots thought that they were coping well. And some people said to us, and we've seen this in other surveys and other reports as well, that they're really happy that the restrictions are in place. They want to keep the illness out, and they're fearful to be exposed to people from the community who might be coming back and forth. So it's important to acknowledge that not everybody feels the same way about this, and we need to take that into strong account. I'm going to return to the societal premises that I wanted to challenge. We've been told that any strategy needs to be perfectly fair, i.e. universally applied. And while that's a laudable principle, some of us have made the point that instead of doing that in a large system where we have very, very many congregate care settings, at least in our province and in most others, let's consider instead targeting some facilities or regional areas and pilot some new approaches, to learn if those innovations can assist as we prepare for the next wave or crisis. And I put a note in here to think about the Alberta Traveller Trial, where Alberta, in concert, the provincial government in concert with the federal government, has started a new trial where people can come in from outside the country, and instead of the usual 14-day quarantine that's mandated, have a rapid test, get a result within 2 days, quarantine for those 2 days, and if they're free and following some very prescribed ways of quarantining and reporting any symptoms, they get another test in 6 or 7 days to confirm a negative test, but they get to get out in 48 hours and be out in the community again. That's a great example of trying something regionally, learning from it, seeing what works, and then applying it to other places. We can do the same thing in targeted facilities, and we know that many of our facilities actually have tried some pretty unique and wonderful things. So here's another societal premise to challenge. We can't afford better staffing ratios and training. And when you think about the numbers that have been reported in the media and nationally about Alberta's per capita dollars spent for healthcare versus Alberta's actual long-term care staff ratios, especially as it relates to aides who do the primary amount of the day-to-day hands-on work, as well as Alberta's relatively low rate comparatively to other places in the training hours required for cares, we're spending our money by conscious decision in certain places and maybe not in other places, and we might need to challenge that. Further, a societal premise, family members cannot become fully integrated members of the circle of care in such care and living facilities. There's just too many legal and operational and risk and safety and training barriers to contemplate doing that. And I'm going to say in very unsophisticated language, I think that's a bunch of bunk. So what ought we do? Immediately, there's a lot of practical ideas out there, such as rapid testing capability. We need to mobilize resources differently, because the impact of not doing so means that people are suffering in the ways that we've described and are dying in isolation. We've seen it in many reports that have just been heart-wrenching across the country about the conditions that some people have been left in during COVID, not intended to do so. So if we mobilize resources differently and rapidly test and then assure that the people who are coming into the facility, to the degree that we can assure that, are not bringing COVID in, we might be able to open up the spaces in a different way for family visitation and for care. Put money and prep time into bringing the designated support person within the formal care circle. I believe that's faster and cheaper than hiring new and training new people. Of course, we do need to hire and train new people. I talked about the pilots earlier. Hire expert folks to be educators and greeters and guides to relieve the burdens from care staff of having to do that, helping people, patient, family, visitors to don and doff safely the PPE, or to learn how to move within the facility to minimize the risk of spread. You can also train volunteers for similar roles. Mobilize the community differently, and maybe if there are designated support persons that are coming into the facility, we support them maximally by some community actions, and that's a compassionate communities approach. We designate the support person and semi-isolate them potentially in their own homes after they've been visiting and caring for their loved one, and maybe they're supported in other ways to be able to do so through their family and through community supports that do their shopping for them or support them to be at home more isolated. We can change the way we do philanthropy so that it becomes an expectation and a really honorable and supported thing to actually, through philanthropy, support these homes as well. In Alberta, we had just a phenomenal simulation effort to train thousands of care staff in ways to safely don and doff, to look at the processes of care within hospitals to make sure that we were minimizing the risk of spread of this infection. That kind of effort can be duplicated within long-term care facilities and hospices to, again, not be perfect, but to reduce substantially the risk so that we can stop visiting restrictions that are causing harm. All that costs money, you say, and I say, agreed. Bring it on, and redistribute. What ought we do in the long term? So I'm not going to go in detail on this. There are many calls to action that experts have made, including national standards and enshrining accountability as an expectation and rights into something akin to a Canada Health Act for long-term care. Some people have said we need to open up the Canada Health Act and bring long-term care in. Others have said it needs to be a companion act, not the same one. Lots of thinking going on about building designs, including safe access, single rooms, spaces for family care, airflow, infection control spaces, new staffing models, better training for staff and families, better funding, supporting more research, and then developing compassionate communities of care. And I'd ask you all to read about those. Many of you are well versed in them already. So my end claims over the very long term, we have all as a society, and I want to emphasize that this is not about blame for those who are managing or running or deciding about the system or funding it. This is a societal thing that's happened. We failed these most vulnerable people and their families and our staff, partly because of those assumptions that I went in through earlier. This is despite the great efforts by many care staff, managers, operators, volunteers, family members who are working hard in tough conditions. We just need to be thinking about all this from a different set of assumptions and biases. There are important things that can be done by governments, funders, philanthropists, researchers, facility operators, health system operators, families, staff, and of course, the community. We'll have to alter our mental model about the place of family members and communities within the care models for people who live while being dependent in care homes. And as well, for the expected place, it's not a luxury, of family members in the circle of living and caring for people preparing for death. Thank you.